Thanks, Leanne. So, the family has been coming to the surgery and had a nursing assessment. And it's also important to remember that often they're exhausted by the time they've had, like 6 people going through a whole check and telling their story. One of the advantages of seeing the whole family together is, to some extent, much of the stories will marry together, but it is important to try and identify whether there's a specific story that's different with each of the individuals. Just remembering that in the visa medical, only Dad, Mum and the 2 older children would have had a chest x-ray, just so as we're putting this into context, and only Mum and Dad would have had the blood test for HIV and probably syphilis. So just sort of understanding that, generally speaking, this nursing check is the first really decent check that they've had for quite some time. And obviously during that time they've identified some health issues. So we have a refugee family. We have Ali, who's got a health undertaking, and he will be organised with the settlement services through Bupa to actually contact and connect with we got a chair. Excellent. Okay, so he'll be connected through Bupa with the TB services, but you as the GP may never hear the outcome of that, and you'll have to proactively engage with the TB services that you know he's connecting with, because the settlement services, you will talk to them and they will tell you. So it's really quite a complex situation to be able to ensure that you can get the information that you need to continue the clinical care. I mean, clearly they're going to be managing the TB stuff, but do they actually know who the whole family is? Are they doing the follow-up? Is your family, even though they've been recalled to the TB clinic to go and get the family check, are they actually engaging with that? That's really good for you and an organisation to continue. Of course, we've got relatively urgent antenatal care that needs to be organised, and we've also got the mental health care that needs to happen as well, because this family's been flagged as potentially having problems. And your job is to continue building the trust. This is actually trust that's built from your admin, from your nurses, allied health if they're working in your practice as well, and also you together, all as a team, building trust, because your patients will see you as a family that they can look to. And in fact, I can tell you one story. One of my patients was in hospital, and she was sick with cancer, unfortunately, and we'd been working together on just about every health problem you can imagine, and then she ended up getting cancer as well, which was really sad. She lay in the hospital bed, and she finally came back, and they told me this story, and the husband was so excited to tell me this story, and it was just this joyful laugh as they said, "Oh, they asked about you. They asked if we had a GP, and we said yes, Dr. K is the GP." And then she said, says the husband, she said, "Yes, she's my mum." And like I'm not. And they were both killing themselves laughing because they knew that it was the wrong word. But what they were trying to say is that our practice had become part of the family. And I think that was a really important message. I'm sure the hospital completely didn't get it. But should I say that here? I know there's a lot of people. Anyway, but it was a really important thing that, they had connected. And I think this is what you're establishing from this moment that the family are there. So you need to identify the significant health issues, which are both the ones that you find, like TB and antenatal care, but also you need to find out the significant health issues that they think they have. In other words, the ones that are really troubling them, like really painful teeth, might be actually the number one. And you need to ensure follow-up. So a lot of people get lost to follow-up simply because they've got so many other things that are happening. And every time you meet, be it with the admin, be it with your nursing team, be it with you, it's about education, health literacy, health systems education. I can't work out half this stuff. How can someone who doesn't speak English work out how to actually get to A to B? Even walking through Marta, it's really confusing, isn't it? Like, which building? How many people could find this easily? So, no English, it's even trickier. So health assessment, the time that takes for the assessment varies somewhat, and the time for the referral varies. You need to identify and focus on the acute health needs, obviously, and then you need to contextualise those actions within the health assessment. And we've actually got some tip sheets to help people with health assessments. But you need to remember that refugees who have arrived in Queensland in recent years, as in the last couple of decades, have had no formal medical health assessment unless they've gone to someone who knows how to do it. There has not actually been a health system that actually does that. We don't have a migrant health centre centre like South Australia and Refugee Health Service like New South Wales, it's different here. And many people have not realised that, so they haven't even asked the questions. Some people do have the health undertaking. Some people have a health alert. So in that departure check, they may have been identified as having a particular problem that needs to be sorted, and the settlement agency should notify you of that. And some people have this magic health manifest, which should actually have been presented to the nurses so that they can actually document whatever vaccinations and things are documented on that health manifest. But it's good to try and track that down. So many refugees, I've said that. Okay, and these are the sorts of things that people have sort of found in research that have been identified. And number one is the bit I want to emphasise there, is that just about everyone needs vaccination. And dental problems are pretty high up on the list, as we've said, and so are social problems, and pregnancy is pretty high as well. So we might have acute health problems, might have public health problems, we might have, so that's obviously HIV and TB, but also I think chronic hepatitis B. If you have a patient who has chronic hepatitis B, so hepatitis B surface antigen positive, and goes through the public health notification process because you did the pathology, then those people do not get followed up by public health. The family do not get vaccinated by public health because they don't have the capacity to do that. So it's all up to us to make sure we ensure that the family is supported with the vaccinations that are required quite urgently. So public health issues, chronic disease, and preventive health issues, all really important. And then ultimately we have nutritional deficiencies, including B12 deficiency. I just emphasise that because a lot of people don't realise that B12 and folic acid deficiency are both important for neural tube defects. And so we need to remember that a lot of the refugees who are arriving may not have good B12. Infectious diseases, some unusual infectious diseases, and sometimes the really simple ones, but all sorts of infectious diseases that we find that we can manage effectively in primary care. We just need to do it. We need to understand the significance of FGM, and usually there's a question around, have you been circumcised as appropriate, and the language is usually used with the interpreter actually interpreting and usually doing that in an appropriate cross-cultural way. Now that's not necessarily my first question when I talk to a woman, and it's often done at the time when I'm doing a pap smear, and I don't usually say, oh good, now we've got a health assessment, let's do a pap smear, welcome to Australia. I really think it's not necessarily the most urgent test. So I think let's just work on the trust bit, but I do offer very early whether or not they want a gynecological test and assessment, and then I can judge from that as to how they prioritise that. And if the answer is not yet, and not now, and maybe not ever, then I will work on that. But if some people are actually really keen, and remember sometimes people have had incredible trauma and they actually do need a really important health check. So a lot of people will volunteer that need. Dental health issues we've heard about, and mental health issues, again, extremely important in this particular family, but often even when it's not flagged. Good history, we've already heard how to take a good history, so allergies, past medical history, past surgical history, past obstetric history. Can I tell you, if your nurse has taken a full obstetric history, please don't ask again. Only ask what you need to ask. If it's all there on the records already, read the records, because people do not want to tell you about all the children that they've lost again and again. We've had many people of refugee background tell us that just telling once the story is too much. To tell again, and only 1 week later or whatever it might be after you've spoken, after the nurse has done the assessment, is really far too much and so unnecessary, re-traumatising people. For what? So you can write it again? Not really an essential piece of information if we just bother to read the notes in the first place. Physical examination, appropriate investigations, and a management plan. The management plan is part of the health assessment. If you're going to claim a health assessment item number, you have to develop a management plan, and you have to give that management plan in writing to your patient. That's part of what we're supposed to be doing with every health assessment. Okay? They say we have to offer it. I have never seen a refugee patient refuse it. So I'm concerned that some people are not actually receiving that part of the health assessment. It's very important. So good history, we've already talked about a lot of that, and I absolutely agree that getting the genogram clear so that you understand, and again, the nurse might very well be able to give you a perfect genogram and you don't need to ask about where people are missing in the family. And diet, again, constipation is a really big issue, and again, I've mentioned mental health. All the systems need to be examined, and we have learnt to do that very, very quickly when we're an intern, and we need to actually scrub up our skills and do it again. You can actually get through a family who's relatively healthy quite quickly if you just remember how you do it from top to toe. So it's actually been really good at honing my clinical skills back to how it used to be. And the thing I need to remember is to look in the ears, check vision, Can't emphasise that enough, and you've just heard the story. And look at teeth. I've never seen so many terrible teeth in my entire life, and usually I have to grit my teeth while I look at their teeth because it hurts my teeth. But it's really important, and I have written so many letters advocating for someone to get seen, not within the next 12 months, because if I had teeth looking like that, I don't want to be seen in 12 months' time. Developmental issues, do look at kids if they can run, jump, skip, whatever they need to be able to do for that age group. And remember STDs, which is not necessarily only in adults, but I don't screen everyone with STD checks. It's just as appropriate. And these are the tests that we recommend. They're pretty much matching the ACID guidelines. There's a couple of slight differences, but this is what I think is practical in general practice. Can I say that if you're actually doing it with private pathology will often only do 2 hepatitis checks. So we've got hepatitis B surface antigen and surface antibody and hepatitis C antibody. All of them are important. I have a great relationship with my private pathology unit, and they know that they're sick of me ringing them again saying, can you also do? And they just automatically do because I did require on the test. So they actually sort of get it now. So if you can develop the same relationship with your private pathology that you don't have to ring all the time and say, can you also do? But those 3 are actually really important, and it saves people going back for yet more blood. Vitamin D deficiency is really, really common. Schistosomiasis and strongyloides are not treated with the big dose of albendazole that they get. So they're 2 tests that I recommend. Strongyloides, of course, is an autoinfective worm and can last for many, many decades. And, you have a perfectly good English-speaking person arriving in your rooms who has strongyloides, and I had that just the other day. She'd arrived when she was 4, and here she was with positive strongyloides, age 24, and had never had a health assessment. And so, give her another 10 years, and she's perhaps got some other health issue that needs immunosuppression. And we immunosuppress her, she will still have strongyloides that's untreated because no one bothered to ask. So, people can be here for a long time and have strongyloides. If you're involved in any way with chemotherapy with your patients who come from refugee background, then please make sure that they've had their strongyloides checked and make sure that it's followed up 6 months later to ensure that it's stayed cleared, and maybe followed up again and again just to ensure that it's cleared. And remember to flag it on your notes so that if they do require immunosuppression, you've double checked again. Because I can guarantee at the moment the breast surgeons haven't really been engaging with strongyloides. I have tried standing on the table in the private surgical doctor's tea room, but I only caught a couple of them before they took me down. So that wasn't a very effective strategy. I'm trying again. Tuberculin skin testing is important with the TB clinic, so know where your TB clinic does it, which is your TB clinic, so that you can actually... Am I in the right spot here? Yeah. Okay. So other tests are just what you think is the right test to do. Obviously, if someone's profoundly anemic, iron studies are useful. If you think they've got malaria, they may have a rapid diagnostic test for falciparum malaria, but that doesn't include all the other malarias. So, febrile person, thick, thin film might be very appropriate. And if you think someone's thinking of pregnancy, you think that it's reasonable to ask them to pay for a varicella vaccine if they're over 19, because it's at the moment we're a little unsure as to how the varicella vaccines are going to be covered for over 19s. But doing varicella serology could be appropriate too. And if you think there's something you need to check for, indigestion, think very carefully about doing Helicobacter. Fecal antigen is the best way to check for that. I can't get people to comply with a breath test, but I can really get a poo sample very easily, so that's a great idea. When they're iron replete, you may find that a hemoglobin electrophoresis for the microcytic low hemoglobin might be worthwhile, but if they're not iron replete, then it might be worthwhile deferring that test for a period of time. And these are the sorts of things that I often see. Schistosomiasis often reduces people's fertility. A number of times I've assisted my refugee women to achieve pregnancy by just treating their undiagnosed schistosomiasis. It's kind of become I get really excited when this happens yet again because it's happening so often. So anyone who wants infertility check, my infertility check is schistosomiasis first. And then we can worry about the other things. It's a much bigger yield I've noticed in my particular practice. Chronic active hepatitis, I had another woman only only 22 years old. She'd been here again. In fact, she's the sister of the other lady. She'd been here again all her life. She'd had her entire schooling here. She spoke perfect English. She was dressed immaculately. And her sister, who I'd treated with the strongyloides, said, "This is my sister and she's been here as long as me and she might have the same germs." She didn't have strongyloides, but even though she'd been vaccinated with her hepatitis B vaccines when she was at school, 13, in those days, that's when she got the hepatitis B vaccine, she actually had chronic active hepatitis. And so she has been spending her entire life with chronic active hepatitis, more than 20 years here in our nation, and no one has diagnosed it. And I just think that's travesty. And I'm hoping that doesn't happen too many more times. She's actually devastated. Iron deficiency, dental issues, we've talked about these. Diabetes in the Syrian Iraqi population, really, really common, people actually arriving with diabetes. But in many of my families, they actually develop diabetes later. Chronic arthritis and occasionally asthma, but again, later on, I often find asthma comes. But again, in the Iraqi Syrian population, ischemic heart disease is very common. We're going to hear from QPAS with Fernando shortly, but I just mentioned transcultural mental health. We'll do an assessment in a cross-cultural environment when you're finding it really, really difficult to get the story. So again, try not to get people to retell the story, because that's often traumatising. But sometimes people won't tell you the story until later. So I had one lady who had severe back pain. I've been managing this back pain for a long time. And then after about 5 years, she finally told me the story as to, which is really relevant to the back pain. And it's made such a difference. We're managing this back pain much more successfully because she's finally been able to talk to me about what really did happen. Immunizations, can't emphasise enough to make sure this is recorded on air. Okay, air is new, and by the end of the year, all the adults will actually have all their vaccines on air. Can you make sure that they go on air, because it doesn't necessarily transfer across? So you need to make sure that your system is transferring across, or make sure it happens however you can. It's really, really important. We're very lucky in Australia. We've got VIVAS, and VIVAS, it will actually tell you whether or not people have had vaccines through the Refugee Health Program over the last recent years. And so it's worthwhile contacting them, as well as looking at ASA and doing whatever you can to find out what vaccines have already been given. And then you can just top up whatever, particularly if, obviously, this is a newly arrived patient, they won't be on your VIVAS. But, I sort of tend to think any patient who's arrived now in my practice who hasn't had a refugee health assessment, that's the sort of process we go through. And remember, many people have been on medications in the past. We just heard the disaster with insulin. Many people have been on medications in the past that they haven't been taking for the last 3 or 4 years. It's hard to find that in a war-torn country. So if you just try and make sure that you understand what they were taking previously and realise that, those health issues need to be investigated appropriately, and you need to ensure that they have the appropriate medications. Now, we have a huge amount of information in the Refugee Health Network Queensland. So if you actually go to the Refugee Health Network Queensland, now did we actually get that website up or not? No. Okay. We click on it and see what happens. I'm really nervous about this. Click on it and see what happens. She says, "I like that spinning wheel." Okay. Click on it and see what happens. Now I can't stop that, can I? Yeah, that's right. Perfect. Okay. Well, that's the end of that then. Once upon a time. You did hear Donata tell me to click on that, didn't you? I'm just making sure you heard Donata say, click on that. Okay, Donata, you're going to make sure. Oh, I'm going to click that one. You don't want me to click that one? No. Okay, so I'm just going to keep going because I can do that. So you also need to make sure, and I can't emphasise again enough, you also need to make sure that Social Security has got all the information that your patients need so that your patients don't go hungry. So I've had patients who have had their Social Security stopped. I'm sure all of you did during the no jab, no pay, where they actually didn't have food. Now, I'm sure that wasn't the intention, because food is actually probably more important than vaccination. But anyway, it certainly makes people come to the doctor quickly, but it wasn't necessarily the ideal way of managing things. Now, some people will be arriving on spousal visas and they won't necessarily have much assistance from the settlement agencies. It varies enormously. And many times I find that I'm doing a refugee health assessment because the person has presented because they're pregnant, and I say, "Oh, that's nice." And they go, "Oh, yes, and here's my husband." "Oh." And then I know now to say, "How long have you been in Australia?" And they've often only been in Australia for the last 5 months. And then we can start the refugee health assessment all over again. So if they've only been here within the last 12 months, thank you, Donata, in the last 12 months, then you need to actually make sure that you get get that sorted with the family. And also, when people go back overseas, which they often do, what we do when we finish our vaccinations is we say, if ever you go overseas, you need to still come and talk to us about vaccinations, because sometimes you need different ones. So we actually plant that seed in their head as they're leaving after their last lot of routine vaccines. So now Ali's actually got moderate English, which is a little unusual, but in this particular case, he's quite excited. He's been doing some health work with the UN while he was in the refugee camp, and he's actually developed some significant English skills. He's offered to interpret for the family because he says, look, it's really a nuisance having someone else in the room like an interpreter, and we'd like to. So the question is, what do you do about that? Well, the answer is it's not always good to have someone from the same family interpreting for family members, because you're actually not getting independent interpreting. Now, I'm not going to click on that. So what are we going to do? No, I'm not going to click it. No. Okay, I'm going to do this part of the talk, and we might look at this video in a moment, I think, because we've got an example of what might or might not happen. While Donata does that, I'm going to say that what we're trying to do is actually deliver a culturally sensitive consultation, and to do that you need to actually have the linguistic components of that consultation covered, and that means that you actually need to use the interpreter service, and you have a doctor's priority line. And I've been working in private practice for a long time, and although I admit occasionally I can't get an interpreter, particularly if it's for a language like Lomo or something, but most of the time I can get an interpreter within 3 to 4 minutes. And the doctor's priority line is an absolute godsend for all us who are in private practice. And I know it's different systems in the hospitals, but everyone needs to know how their hospital system works so as you can enable that from happening. So be a reflexive practitioner. Understand your cultural background and how that's actually going to inhibit, perhaps, or assist you to engage with your patient. And also be responsive to those needs. The training of the interpreter varies, and you may need gender concordance to be an issue. So obviously if you're dealing with a woman, and particularly with pregnancy, you're probably going to need a female interpreter. And remember, sometimes people come from different countries even though they speak the same language, so the cultural concordance may not exist in your room, and that occasionally is a problem, though not always. Ensure that everything is interpreted. So the patient actually is going, the patient's words are going to be interpreted and your words are going to be interpreted, and there's often a lot of toing and froing. The interpreter can get very tired. And you need to really avoid the traps. Am I just going to keep going here? Here we go. You need to avoid the traps. So having dad interpret can be a problem, but also just imagine having a woman come in with her 12-year-old son. 12-year-old son was brought in fact, out of school. I have actually sent kids back to school because they're not supposed to be there. So I usually make a big deal. If I see a child come more than twice with mum or dad, I make sure that they're going back to school. And usually the family eventually appreciate the fact that I've done that. But it is something that we need to actually actively ensure that the children are going to school and not being reeled out as interpreters. So imagine 12-year-old son coming in with mum, and you say, oh, good, child's here, don't need to worry about that interpreter. And we ask mum what's wrong. Chances are she's going to show you the sore toe. Chances are you're going to look at the toe, wonder what's wrong with it, and say, oh, well, we'll just put a Band-Aid on it and send them out. Cool, it was only 5 minutes and they didn't even speak English. Like, that's a really inappropriate thing, but that's exactly what I've seen happening. Okay, just to show you how inappropriate these consultations are. Now, that woman is likely to have had some period problems. Maybe she was pregnant. There is no way she was going to tell you what was really going on in her life, because her 12-year-old son was not going to be part of that conversation. So you've actually just stopped that woman from having appropriate health care. And that is happening over and over again. And it's exactly in that frame that I'm trying to describe. So if you can do anything to advocate with your peers to ensure that that isn't happening. So most of the time I find using an interpreter reduces the time that I actually spend with my patients. The first time it might take longer, but because I've actually taken the time the first time, everything else is sped up. And I don't end up with someone presenting and presenting and presenting because they're actually not happy and they're trying so hard to get the care that they need. So in the hospital system, sometimes there's people who speak the language, and isn't that good? We'll just drag them over, but they're not trained. Ethnic differences occasionally can interfere, and I certainly had that with some of the Vietnamese communities with the north and south differences in the past, and I believe the Rwandan community have had similar problems. But it's just something for us to just be aware of. And sometimes the interpreters help, and sometimes I don't find out until the next consultation with a new interpreter, when the new interpreter informs me that last time they were here they got a lecture about how awful they were and how I thought they were the worst person under the sun, and I'm going, I don't think I said that. So some things don't really translate very well, and we have to be very careful that we present the things appropriately. Have your thoughts organised, go simple language. not simplistic language, but simple language. Don't make it complicated, because sometimes when we're getting a bit nervous, we can actually really find high-level, almost medico-legal speak, just to make sure it's really complicated, and none of that is necessary, and we wouldn't even use it for the average patient that comes in that speaks English. But we suddenly, because we're confronted with a different language, we find our own different language that we're comfortable with, it seems. Speak to the patient. The interpreter's speaking English, but speak to the patient who's not speaking English, because you need to speak to the patient. The patient is the one who wants your care. And just smiling and acknowledging them actually helps build that trust, and it's really, really important to do that. Single questions. This has been my big problem. I tend to ask 3 questions in a row and wonder which one the no went to. Make the instructions relevant to the patient's life. It is so common for us to say, take 1 3 times a day, and that does not translate in just about any language except dreimal am Tag, which is German, and that seems to work in German. So in any other language, 1 3 times a day is not a concept. So 1 with breakfast, 1 with lunch, 1 with dinner, or something like that is much better to say it in the first place. Otherwise, you just got to interpret what you're interpreting. It's kind of weird. Confirm that the patient understands. When the patient then says, so I take 3 at once, you kind of know I actually said 1 3 times a day, and obviously that was cross-culturally not appropriate. Okay. So your health assessment billing, basically it's a 703, 705, 707, often 707, dare I say. Humanitarian entrants of all different visas are entitled if they're of refugee background. So just read the details and work out what actually fits. And if they're a resident in Australia in the last 12 months, you're allowed to do that. They need to have access, obviously, to Medicare to be able to charge a Medicare number. You must document consent, and you must do all the things that I said you need to do, including the management plan, to be able to claim the health assessment. But once you've done that management plan, if that person has a chronic health problem, you can do it as a GP management plan as well. You can do a team care arrangement, and you can do all the reviews that are required to ensure that you actually deliver really good quality care with your nurses involved as well. And so you can actually deliver really good high quality general practice care, and you can actually get some funding, maybe not adequate, but some funding that's going to help you manage this patient and their family. Mental health pathway, mental health plan, particularly in this family, might be very helpful. So now we actually have the practice administration component, and your patient that's coming to you as the best ever GP and nurse is not going to come to you unless your admin team actually lets them get to you, because they need to be able to book the appointment. So they need to actually have all the usual details, and sometimes it's hard to actually get all those details that they need to fill out, and they need to actually be able to navigate the language just like you. And we're now going to hear from Claire, who's going to talk all about those issues.